Can somebody confirm?
Yes, sir. Yes, sir. You are audible and visible.
Yeah, thank you. I would like to thank the organizers for inviting me, and over the next about 20 minutes, 15 to 20 minutes, I shall cover issues on fever with hepatorenal syndrome. I'm going to only highlight upon certain aspects, so I may not be doing a comprehensive talk. Dr. Vibhuti Saha gave an excellent talk on the various aspects of the fever with a rash. And I would like to start with this picture, which I actually found in Turkey, in Istanbul, where I saw this in a shop, genuine fake watches. And that is exactly what we would see in a patient who comes with fever, liver and renal involvement. Now, this was a paper published about 4 or 5 years ago from Central India, which looked at the etiology and clinical profile and outcomes of patients with fever. And you'll see that the commonest causes of a hepatorenal syndrome with fever, and I'm using the term hepatorenal just to imply that there is liver and kidney failure. The top 4 causes were septicemia, malaria, acute pancreatitis, and dengue fever. And if you look at that, the mortality was very high in, the serum bilirubin and the serum creatinine were raised in all 4. Anemia was seen, and the mortality was also high in all these conditions. So it is actually septicemia which is the commonest cause for a person who presents with fever and typically liver and renal involvement. And this is a picture of a patient who had meningococcal meningitis with septicemia. And this was the picture he presented. We had this case a few years ago. But more commonly, if you look at the important tropical causes of jaundice and fever, you'll find that it could be due to hepatitis with fulminant hepatic failure. Of course, I said bacterial sepsis, malaria, which could be either falciparum or vivax, even typhoid fever, if untreated, can lead to problems, leptospirosis, scrub typhus, dengue, amoebiasis, brucellosis, and macrophage activation syndrome, what we refer to as hemophagocytic lymphocytosis syndrome. So I'm going to cover only 3 or 4 and give you only 2 or 3 points to take home amongst these. Now, this is a patient with dengue, and this is the characteristic rash we see in dengue. Usually, it is not the petechial, it is not the bleeding rash which we see, but just a toxic erythema which is seen most often. Please remember that dengue is not a cause for pyrexia of unknown origin. There is something called the rule of 14 in dengue, where a person returning from an endemic area back home to the Western hemisphere, starting with fever after 14 days, or anybody who has a fever which lasts beyond 14 days cannot have dengue. This is a rule of the thumb. We have seen very nicely the diagnosis. The NS1 antigen is believed to last for up to 7 days, and the IgM starts around the 4th day and extends for several months. But in real life, we found that quite often the NS1 antigen is found only in the first 2 or 3 days, and the IgM becomes positive after the 5th or the 6th day, which means if you do a dengue serology between the 3rd and the 5th days, inevitably it may be negative for both NS1 and IgM. So this is to be kept in mind when you're evaluating a patient with dengue. The other problem is the issue of transfusion of platelets. This has been said a lot of times in the last couple of decades. Earlier, we used to admit the patient in the ICU if the platelet count was less than 50,000, transfuse if the patient platelet count was less than 50,000. But now it is very clear based on the WHO recommendations and what we have seen. It is generally packed cells are recommended if there is a blood loss of 10% or more of total blood volume, and platelet transfusion is recommended. Definitely no role for platelets if the platelet count is more than 20,000. You can consider, please remember, it may be given, it is not mandatory. Consider if it is less than 10,000 or if there is active bleeding from any side. So these are the 2 things, which means we have become very conservative in our current management of patients with dengue, and almost never ever give platelet transfusion for our patients. The 3rd point I wanted to convey is something which is new about the dengue vaccine. This is a chimeric yellow fever strain of dengue tetravalent vaccine, which covers all the 4 strains of dengue. It is the only licensed vaccine. The phase 2 immunogenicity study was done in India, and it has been licensed in about 13 countries. But there is a lot of controversy over this because it was seen that in patients who are given the first dose of dengue vaccine and who developed dengue after the first dose, the patients had very severe dengue, which means the first dose of the dengue vaccine acted as though it was a natural infection. And subsequently, when the patient had the dengue fever for the first time, this caused an immune reactivation and a significantly severe disease. So that is why the recommendation was, it is recommended only in countries where the seroprevalence is more than 70%, which means that most of the people would have already had one episode of dengue. And to prevent the further complications, this vaccine helps. If the seroprevalence is between 50 and 70%, it is acceptable, but the impact may be lower. And it is definitely not recommended where the seroprevalence is less than 50%. Studies of seroprevalence done in India have not categorically given a value over 70, and that is why this vaccine has not been approved in India. The other condition which causes both liver hepatitis and renal failure is a person who presents with scrub typhus. This was a few years ago, and when this was believed to be a killer disease which had come to Chennai, but now we are very familiar with that. It was very clear even long ago that India was highly endemic for the Orient Chiasotsugamushi or the scrub typhus, and this again is a rash which is seen in dengue. In scrub typhus. So you'll find that this kind of a toxic erythema is seen in several tropical fevers, which is not specific for any one of them. This shows the clinical features. This is from a paper in Lancet in 1945, and this is our experience at Apollo hospitals about 6 or 7 years ago. And if you look at in 1945, mental changes were seen in 100%, headache in 100%, cough in almost 70%, myalgia, nausea, lymphadenopathy 92%, SR was seen only in 11%, and splenomegaly and a rash. Whereas the recent studies showed that headache was seen in up to 80%, cough in 50%, myalgia 50%, jaundice in 7%, mental changes, this was 100%, this was less than 4%, probably because of earlier diagnosis. And the SR, that is the tick bite area, was seen in almost 50% of our patients. So again, with time, we are now closely examining all patients who come with fever to look for an SR, and it is there. It simplifies the diagnosis very, very easily. We have seen SR set in all places, in the neck, in the arm, in the back, and even going beyond, very difficult, under the breast, in the eyelid. You'd see this patient had an eyelid SR. This is again just at where the underclothes are tied. This is area covered by the panties, and even on the penis. So please always strip the patient to see if there is any evidence of SR to come to a diagnosis. The practice points for scrub typhus would be, it is a re-emerging infection and always look for an SR. Typically, it presents with leukocytosis, thrombocytopenia, a cholestatic hepatitis and fever, and sometimes even a subacute meningitis. Atypical pneumonia with interstitial infiltrates are seen, and sometimes it may present with fulminant sepsis with multi-organ failure. Fortunately, all you need is one dose of doxycycline and the patient dramatically improves. Serology is useful, and if in doubt, always start doxycycline. The third illness is malaria. Malaria can be conveniently divided into uncomplicated and complicated. Uncomplicated is just like any other undifferentiated fever, which may present with fever, myalgia, back pain, chills and sweating, dry cough, splenomegaly, and even nausea and vomiting, which is very difficult to diagnose malaria in most situations. This is uncomplicated. So in any endemic area, you need to do the malarial parasite. And complicated is when they, of course, present with liver, renal, and neurological involvement with lactic acidosis. What I want to highlight regarding malaria is the fact that artemisinin combination therapy is now established for falciparum infections. And this is now routinely given for all cases of suspected falciparum, but we are finding falciparum which is resistant to artemisinin combination therapy in this part of the world, typically Thailand, Laos, Cambodia, and Myanmar. This area we are seeing, and this is very likely it may spread to other countries nearby. There have been clinical cases which have been shown to be resistant in India, but we don't have molecular studies to prove this, because sometimes difficulty in controlling can be due to high parasite index. It can be due to poor host immunity, and sometimes also poor pharmacokinetic and pharmacodynamic aspects of the drug given. In severe malaria, the recent recommendation is to use a higher intravenous artemisinin dose. Earlier 1.2 has been replaced by 2.4 given stat at 12 hours and then 24 hours and then every 24 hours. Alternatives for falciparum will still include intravenous quinine for a patient with severe malaria, or intramuscular artemether can be given. Once they are able to eat or drink, we can give on to again artemisinin combination therapy, and do not use mefloquine because there is a high risk of post-malaria neurological syndrome. This is the WHO recommendation. Again, various combinations. We have this available in India: artemether, lumefantrine, dihydroartemisinin with piperaquine. So several combinations are tried at least for 4 to 6 days. The duration should be a minimum of 3 days, and in young children, a higher dose of artemisinin is recommended. To reduce the transmissibility, even though falciparum does not cause, a liver phase and subsequent reactivation, to prevent transmission, 1 dose of primaquine 0.25 milligrams per kilogram is recommended for all patients. What is the role of vaccine? There is one vaccine which is currently recommended and approved, the RTS-AS01, which is in children. Most of the malarial vaccines are anti-Sporozoid vaccine. So this vaccine was tried in Africa, 4 doses for children between the age of 5 to 17 months. And this was shown to have good benefit in the older children, but not in the younger children. They needed a booster dose at 28 months. And it was also seen, surprisingly, that children later, after 3-4 years of vaccination, when they develop malaria, it could be a severe malaria, or in other words, they had a higher propensity to develop malaria if they had received the vaccine earlier. These for chemoprophylaxis, pregnant women, it is sulfadoxine pyrimethamine. Moderate transmission, again, sulfadoxine pyrimethamine. Doxycycline can be used. Travelers, what is recommended is atovaquone proguanil, which is unfortunately not available in India, doxy or mefloquine or even primaquine. Please remember that long-lasting insecticide-treated bed nets are the sure shot and the most effective way in preventing transmission. Indoor spraying of insecticide helps. Repellents, topical or spatial, have been tried, but convincing protective effect. And similarly, the role of these coils or these mats do not stand the test of science or reason, and there is no evidence. It's only bed nets and insecticide-treated bed nets which have been found to be useful. Lastly, Zika, as Dr. Bibhuti Saha said, is something which we should always be wary about. This is very commonly confused with dengue. It was first seen in 1947, and subsequently from early part of this century, we have had several outbreaks, and we have seen several cases reported in India also. In fact, a study done in 1954 showed that even in India, people had neutralizing antibodies against Zika. This is currently the outbreak which started about a decade ago in parts of South America and parts of Polynesia and Southeast Asia. And you have seen local endemic transmission in these areas also. The infection rate is about 73%, and symptomatic attack is seen in only 1/5 of patients who are infected. Adults are more likely to present for medical care, and 20% symptomatic may present with myalgia, fever, rash, joint pain, and conjunctivitis. Conjunctivitis in a patient who has dengue has to be strongly suspected, as that could be due to Zika. Symptoms quite often resolve in 5 to 7 days. It is self-limited, and mortality is very rare. Lymphopenia, thrombocytopenia, elevated creatinine and transaminases, hepatorenal picture can be seen in patients with Zika also. So this is something we have to keep in mind. So lastly, I think we have to be very clear about the perception which is seen amongst doctors regarding lab tests. In fact, today I had a patient who presented with 3 days history of fever, hepatorenal syndrome, and shock, given antibiotics, and all tests were done. Today I go to the nurse and she says, "Sir, the tropical panel is done. He is negative for dengue, malaria, typhus, and leptospirosis." How? Because they have done leptospirosis IgM, scrub typhus IgM, dengue IgM, and malarial parasite. So please remember, it is very important how you determine what test to be done at what time. Timing of tests, especially serology in endemic areas, should be very careful. And also, if you're doing the serological test within 5 to 6 days of onset of disease, inevitably a negative test does not rule out infection. So these are simple things for all postgraduates to keep in mind. And lastly, I would like to leave you with this slide of Dalai Lama. I think we need to make a difference. If you think you're too small to make a difference, try sleeping with a mosquito. So I'm going to stop here. I know we are already running late. So if there are any questions, I'll